Hello everyone, this is Dr. TSR. Today I am here to start my flowchart series number 1. So the flowchart series number 1 is mainly for the evaluation of primary amenorrhea. So let us study how to evaluate a case of primary amenorrhea. As we all know, primary amenorrhea means the lady has not menstruated yet, at least once in her time. So what you will ask? You will ask the history. History wise she complains of not attained menarche. And you will do physical examination to look for whether there is any secondary sexual characteristics present or absent, right? So that is the main thing. You look for secondary sexual characteristics. If secondary sexual characteristics is present, if the secondary sexual characteristic is present, if it is yes, then you do UPT, urine pregnancy test. If UPT is positive, the story is different. If UPT is negative, what we do is do the ultrasound. If UPT comes to be negative, then what to do? We'll do ultrasound, USG. If UPT is negative, secondary sexual characteristic is present, then I will do ultrasound. So to look for whether what is the genitalia, whether it is internal genitalia is uterus or not, uterus present or uterus absent. Okay, if uterus is present, that means it is having normal internal genitalia. The girl is having normal internal genitalia, so you should think of outflow tract obstruction. Okay, so any outflow tract obstruction such as transverse vaginal septum or imperforate hymen. So evaluate for that. If there is no outflow tract obstruction, you evaluate other causes. Evaluate for other causes. If it is not there, evaluate for hormonal imbalance or something like that. Okay, but mainly it will be like this. If when there is secondary sexual characteristic present, but ultrasound there is uterus, then it mainly be outflow tract obstruction. If there is no uterus, then what we have to do is proceed with karyotype. Okay, if the karyotype is normal, that is XX, if the karyotype is XX, then the diagnosis is Mullerian agenesis. So you should think of Mullerian agenesis or MRKH syndrome. If the diagnosis is XY, then you should think of androgen insensitivity syndrome or testicular feminization syndrome. This is one part of evaluation, that is if the secondary sexual characteristic is present and UPT is negative. Okay, now let us go for if the secondary sexual characteristic is absent. What to do if the secondary sexual characteristic is absent? So in here, when the secondary sexual characteristic is absent, you check FSH level. Okay, serum follicular stimulating hormone. If the FSH is high, it can be two types. If FSH is low, less than 20 international unit per liter, or FSH can be more than 20 international unit per liter. If FSH is less than 20 international unit per liter, you check for, you do prolactin, you do MRI, and you do thyroid function test. Okay, if FSH is very low, less than 5 international unit per liter, remember if you are writing milli international unit, write as ml. If you are writing international unit, write as liter. Okay, if FSH is less than 5 but others are normal, like MRI is normal, TFT is normal, then you think of either hypothalamic dysfunction, hypothalamus there is problem, or it can be even the pituitary problem, pituitary dysfunction, or there can be abnormal TFT can be abnormal, or there can be increased prolactin, hyperprolactinemia, or there can be MRI problem, that is structural abnormality, adenoma, microadenoma or macroadenoma. Okay, or FSH can be between 5 to 20 also, that I will tell. If we will go for FSH more than 20, if FSH is more than 20, that means ovary there is problem, ovary is gone here, ovary dysfunction. That's why the negative feedback, according to the negative feedback, FSH is increased. Ovarian dysfunction means you do karyotype. If the karyotype is normal, that means she has some problem with her ovary, ovarian insufficiency. If the karyotype is abnormal, mainly it will be Turner syndrome. Okay, so that is about FSH more than 20. I have told you FSH less than 20 also. I have told FSH less than 20, you think of hypothalamus, pituitary, thyroid, all those things. FSH is more than 20, you will think of ovary problem, that is ovarian dysfunction. So what to do in between? FSH is between 5 to 20. If the FSH um, if the FSH is between 5 to 20, if the FSH is between 5 to 20, check for whether virilization is present or not. If the virilization is present, yes, or virilization may be absent, then you think of testosterone and dihydroepiandrosterone sulfate. You check testosterone and dihydroepiandrosterone sulfate. If the virilization is absent, then you check for bone growth, whether the bone growth is normal or abnormal. If the bone growth is normal, then nothing, there is no problem with whatever this FSH level. If the bone growth is delayed, it can be constitutional delay in growth, that is constitutional delayed puberty. Okay, constitutional delay, you think of constitutional delay. Now we'll go for this, when you do this testosterone and dihydrotestosterone sulfate, this I will write it here. If you're when you get a testosterone and dihydroepiandrosterone sulfate, if both are normal, what to do? If this is normal, then you evaluate you think of some other causes of secondary amenorrhea, not like PCOS or some tumors. You think of other causes of secondary amenorrhea, you will think of some causes. So like that, any uterine problem, those things we should think. If testosterone is more than 80 nanogram per dl, or dihydroepiandrosterone sulfate is more than 300 nanogram per dl, that means there is increase in the level of androgen, right? So this is hyperandrogenic. Because of this hyperandrogenic, there is anovulation. So if that is the one thing, when one diagnosis you will get hyperandrogen is there, it can be because of PCOS, early PCOS, so there is hyperandrogenic anovulation. But if the testosterone is more than 200 and dihydroepiandrosterone sulfate is more than 700, then you should do adrenal MRI. You should do MRI of adrenal and look for any adrenal tumor is there which is secreting androgen. Androgen is secreted by adrenal gland, na? So any adrenal gland tumor is there or not, you have to rule out. So this is in brief about how to evaluate a case of amenorrhea. So this is me, Dr. Tejaswini SR. Kindly subscribe to my channel, like, share and subscribe for more such videos. Thank you.